All right, let's dive right into this explainer. Today, we're taking a rigorous academic look at the pathophysiology and clinical management of immunobullous diseases. These are highly complex, potentially life-threatening conditions where the immune system fundamentally compromises the structural integrity of the skin. By analyzing the precise cellular anatomy involved, we can actually demystify exactly why these clinical presentations look the way they do.
Here is our roadmap for today. We'll start with morphology foundations, then tackle the pemphigus family, move on to the pemphigoid family, explore dermatitis herpetiformis, and finally wrap up by distinguishing all three diseases. Okay, let's jump into section 1, morphology foundations.
So, a foundational requirement here is defining vesicles and bullae strictly as fluid accumulations that are restricted to specific anatomical depths. A vesicle, it's just a small, fluid-filled sac. A bulla is simply a larger accumulation. But remember, it's the anatomical depth, not the size, that really dictates the pathology we're dealing with.
And that anatomical depth establishes an absolutely vital clinical distinction. Think about it. If fluid builds up within the epidermis, an intraepidermal blister, the roof of that blister is incredibly thin and fragile. In the clinic, this presents as an oozing, denuded surface because it ruptures so rapidly. On the flip side, if the fluid accumulates below the epidermis, you get a subepidermal blister. Because the entire thickness of the epidermis is acting as the roof, these blisters are characteristically thick, tense, and structurally resilient. Moving right along to section 2, the pemphigus family.
Let's walk step by step through the pathophysiology of pemphigus vulgaris. This is all about the autoimmune destruction of desmoglein causing acanthalysis. Picture a healthy epidermis. Your keratinocyte cells are essentially glued together by structures called desmosomes, which rely on proteins like desmoglein 3 and 1. Well, in pemphigus, pathogenic IgG antibodies come in and specifically target those desmoglein antigens. When that happens, the cellular glue literally fails. The keratinocytes lose their adhesion and just fall apart. We call this specific process of cellular separation acanthalysis. And because this destruction is happening within the epidermis, we get those highly fragile intraepidermal blisters we just talked about.
Clinically speaking, pemphigus vulgaris is the most prevalent and the most dangerous variant, accounting for over 75% of cases. Because the blistering is intraepidermal, the lesions are intensely flaccid. They rupture rapidly, leaving widespread, incredibly painful erosions. You'll definitely want to keep an eye on the mucous membranes, as oral lesions almost always show up first. Also, because the epidermis is fundamentally compromised, you get a highly specific positive Nikolsky sign. That means if you apply shearing pressure to visually normal skin, the upper layers literally just shear off. And if we look at direct immunofluorescence, you'll see this destructive intercellular net-like pattern of IgG deposits. No, we absolutely have to highlight this number, a 15% mortality rate. This underscores exactly why pemphigus vulgaris demands aggressive, high-dose systemic steroids. We're talking 80 milligrams of prednisolone to upregulate desmoglein. Historically, before steroids, this disease was almost universally fatal due to extreme fluid loss and secondary infections. Even today, with treatment, the mortality is no joke. We have to hit the immune system hard to reduce inflammation and stabilize those cellular junctions, often bringing in steroid-sparing immunosuppressants like azathioprine or rituximab to manage the disease long-term.
Before we leave pemphigus, let's briefly distinguish two fascinating variants, vegetans and paraneoplastic. Pemphigus vegetans tends to localize in flexual regions, presenting as these heaped-up, cauliflower-like weeping plaques in the groin or body folds. Paraneoplastic pemphigus, however, is a massive red flag. It serves as a critical indicator of an underlying malignancy. If you see severe, intractable blistering, especially with pronounced stomatitis, you absolutely must screen for neoplasms like thymoma, Castleman's tumor, or lymphoma.
All right, on to section 3, the pemphigoid family. Contrast this pathophysiology with pemphigoid. Here, the IgG attack happens much deeper, right at the basement membrane. Instead of targeting the glue between the epidermal cells, pemphigoid antibodies attack the anchors holding the entire epidermis down to the dermis, specifically antigens known as BP230 and BP180. The antibodies bind, they activate the complement system, and boom, an inflammatory cascade starts. The result? The entire epidermis lifts off the dermis as a single, intact sheet. Because of this deeper subepidermal separation, the clinical profile is a stark contrast to pemphigus. For starters, the Nikolsky sign is unequivocally negative, and mucous membranes are typically spared.
Since the full thickness of the epidermis serves as the blister roof, you get these thick, tense bullae that really resist rupture. This is a chronic, itchy disease that mainly afflicts the elderly, often starting out as intensely itchy, smooth red plaques. If you biopsy it, you'll find a subepidermal blister packed with eosinophils. And on direct immunofluorescence, a continuous, linear band of IgG and C3 deposited strictly along the basement membrane zone. The pemphigoid family also encompasses some really diverse variants. Take pemphigoid gestationis, for instance. This is a pregnancy-induced manifestation that usually remits after birth, though it still requires systemic steroids. A quick tip here, definitely avoid oral contraceptives as they can precipitate a relapse. Then there's cicatricial pemphigoid, which is a profoundly scarring variant targeting distinct basement membrane proteins like laminin 5. It disproportionately attacks ocular and oral mucous membranes, and the subsequent scar tissue in the eyes can actually cause irreversible blindness. Let's shift gears to Section 4, dermatitis herpetiformis. The crucial point for dermatitis herpetiformis is its pathophysiology. We are looking at IgA antibodies targeting tissue transglutaminase due to a gluten-sensitive enteropathy, essentially celiac disease. Even if the patient has zero bowel symptoms, they possess a severe gluten sensitivity. The body produces IgA antibodies that cross-react with transglutaminase in the skin. Clinically, this erupts as grouped vesicles and urticated papules heavily concentrated on extensor surfaces, so think elbows, knees, and buttocks. And guys, it is ferociously itchy. You'll rarely see intact blisters in the clinic because patients scratch them away, leaving grouped excoriations. Under immunofluorescence, we see granular deposits of IgA concentrated in the dermal papillae. Managing this requires a dual approach, a strict, thoroughly monitored gluten-free diet paired with dapsone. The diet is the ultimate cure, since it stops the antigenic trigger, but it takes many months for the IgA deposits to clear from the skin. So, for rapid relief from that agonizing itch, we use dapsone. But you have to be careful. Dapsone isn't without risks. We must diligently monitor blood counts for drug-induced hemolytic anemia, particularly in patients with a G6PD deficiency. Finally, let's wrap up with Section 5, distinguishing the three diseases. Take a close look at this slide. It consolidates all of our anatomical and clinical findings. It becomes incredibly clear how blister depth dictates the physical presentation. Pemphigus vulgaris is defined by superficial intraepidermal attacks, yielding flaccid blisters, a positive Nikolsky sign, and almost always affecting the mucous membranes. In contrast, bullous pemphigoid and dermatitis herpetiformis are subepidermal, producing tense, intact blisters and a negative Nikolsky sign. Clinically, pemphigoid shows up as large bullae on red plaques in the elderly, whereas dermatitis herpetiformis gives you those intensely itchy grouped excoriations, primarily on the extensor surfaces. Taking our synthesis a step further, this table maps specific autoantibody targets to their unique immunofluorescence patterns, the molecular fingerprints of these diseases. Pemphigus targets desmoglein, generating a net-like IgG pattern, and requires high-dose systemic steroids. Pemphigoid targets the basement membrane anchors, producing a sharp, linear IgG band managed with moderate steroids. And finally, dermatitis herpetiformis targets tissue transglutamase with IgA, resulting in granular dermal deposits managed by dapsone and a strict gluten-free diet. So what does this all mean for the future of dermatological pharmacology? I'll leave you with this academic provocation. By identifying precisely which molecular anchors are under siege, we pave the way for targeted immunotherapies that neutralize only the pathogenic antibodies, rather than employing broad systemic immunosuppression. Just imagine how a precise biologic agent could alter the severe mortality rate of pemphigus. It's an absolutely crucial frontier in molecular medicine. Thank you so much for joining me for this explainer.